اوكي. انا احمد شنا. قريت بكري في الصيف، ومن بعدها قسنطينة. من بعدها اعطوني ساعة كنت من الاوائل، اعطوني بورصة لترونجي. الوقت هذاك كانت متوفرة. دونك رحت قريت في اسكتلندا، يعني تحصلت على الدكتوراه هنالك في الكيمياء العضوية. لكن من بعدها قررت قبل ما نرجع الجزائر، قلت نروح لأمريكا ندير بوست دوك. وبالتالي رحت لأمريكا سنة 1990، قبل ما تولدوا الكل تقريبا. دونك رحت جامعة نيويورك. بديت نخدم على حاجة يعني مختلفة. بديت نخدم على لا دي ان اي دامج اند ريبير. بديت نخدم يعني فيليير جديد. بديت نخدم في البايو تكنولوجي والبايو كيمستري وهكذاك. دونك خدمت واحد الطروازون ثم. ومن بعدها بعد عامين الحقيقة جيت باش نرجع الجزائر. بعدها يعني الوضع في الجزائر بدت العشرية كما يقولوا السوداء، وبالتالي المسار تاعي تغير وبقيت في أمريكا. ومن بعدها رحت جامعة بيركلي. بقيت اشتغلت حوالي 6 سنوات ثاني على دي ان اي دامج اند ريبير، لأنه دي ان اي دامج هو بداية المراحل الأولى في بداية السرطان. دونك اشتغلت حوالي 6 سنوات في جامعة بيركلي في معهد لورانس بيركلي ناشونال لاب، هو جزء من وزارة الطاقة الأمريكية. ومن بعدها قررت أني نخرج من الأكاديمية، ورحت للإندستري. وبالتالي بديت أول شركة بديت نخدم فيها هي يسموها شركة، هي أكلارا بايو ساينسز. يخدموا على يسموها لاب اون شيب. لاب اون شيب هو يعني مايكروفلويدكس. لما بدت الفيليير تاع مايكروفلويدك في البداية تاعو، اشتغلت هنالك سنوات. وبالتالي كان عندي جروب تاعي نخدموا نديروا جين اكسبريشن ملتيبلكسي. معناها نقدر ندرسوا الجينات، عدد كبير 20 30 50 حتى جين مع بعضهم. يعني بدينا نشتغل في هذه الشركة. ثم بديت نشتغل ثاني بعدها يعني على الكانسر، السرطان. بدينا نخدموا طورنا طريقة جديدة يسموها فيراتاك تكنولوجي، وهي تقدر تقيس البروتينات الموجودة في السرطانات، في الخلايا السرطانية بدقة كبيرة. وهذه تحدد العلاج. الطبيب يستعملها الطريقة هذه للعلاج، لأنه overexpressed proteins in cancer cells يخلوا الطبيب يختار أي دواء. المهم اشتغلت في الأونكولوجي، وهي الأونكولوجي هي كما يقولوا هي السرطان، في حوالي 8 سنوات. ومن بعدها يعني الشركة تاعنا هذه يعني نقولوا ميرجد مع شركة أخرى يسموها فيرولوجيك. يعني فيرولوجيك هذه الشركة أخرى يعني كانوا يديروا اتش اي في والاتش سي في والحاج انفكشس ديزيز، الأمراض المعدية. ونحن عندنا السرطان، جهة تاع السرطان. وبالتالي الشركة تغير الاسم تاعها إلى مونوجرام بايو ساينسز. ومن بعدها يعني بديت نخدم ثاني في حوالي 7 سنوات الأخيرة تقريبا. راني نخدم في البايو ماركر على نيورو ديجينيراتيف ديزيزز كما ألزهايمر، يالاز، أماس. المهم في سنة 1900 لا 2000 و2009 اشترتنا شركة كبيرة جدا، وهي يسموها لاب كورب. لاب كورب هي أكبر شركة أمريكية ديريكت دايجنوستيك. عندنا حوالي 75 ألف عامل. فيها يعني منتشرة في أوروبا، في الصين، طبعا في أمريكا، في الأماكن الكل. نديروا أكثر من 500 مليون تيست، ميديكال تيست سنويا. عندنا أكثر من 200 يعني جينيتيك تيست. في أيام تاع كوفيد عملنا يعني أكثر من 40 مليون بي سي ار تيست. كنا من البرنامج الوطني الامريكي تاع سيكونسين تاع الكوفيد فيروسز، يعني الفيروس على بالك عقب بيتغير، وبالتالي ياخذوا عينات من مختلف من امريكا ويديروا لهم سيكونسين باش يشوفوا التغيرات هذه. تقريبا 10% من العينات انها درنا لهم سيكونسين. المهم انا الان اشتغل في يعني في عندنا مجموعه تاع الريسيرش اند ديفلوبمنت. دائما انا في البحث العلمي في الحاجات الجديده، وبالتالي نحن نطوروا يعني دي تيست جدد، يعني امراض جديده نطوروها ونخرجوها وتصبح تستعمل للمرضى، او كذلك ان جزء كبير الشركه انها نساعدوا الشركات اللي تطور في الادويه، نعملوا معاهم اللي نقول لهم كلينيكال ترايل، هي التجارب السريريه. بالتالي التجارب السريريه كما تعرفوا عندما يكون دواء جديد باش يجربوه على 3000 او 10000 يعني مريض مثلا. نحن نقوم بالتجارب بهذا اللي تيست هذا، نساعدوهم على تطوير الادويه لانهم يديروا متابعه للادويه. مثلا عندما يعطوا المريض دواء مثلا يشوفوا الهاف لايف تاعو مثلا في الجسم، الدوزاج، انه ينقص من البروتينات اللي الدواء اللي راح يعطيها مثلا ولا لا. دونك يعني عندنا جانب كبير من الكلينيكال ترايل، نديروا مانجمنت تاع كلينيكال ترايل، ونديروا تيستين، ونديروا تاع الادويه الجديده اللي مازال ما خرجتش ابدا للسوق. المهم الحياه تاعي كما يقولوا دائما الحمد لله يعني في حاجات جديده، وبالتالي غير ممله الحياه، ويعني حاجات. ونحضر دائما نروح المؤتمرات على الاقل مرتين في السنه، نروح المؤتمرات يعني عالميه هنا في امريكا، يعني كما Society for Neurosciences ولا American Academy of Neurology، ولا على يعني مختلف الأمراض مثلا السرطانية أو الأمراض أخرى اللي نشتغل عليها. المهم هذه بصفة يعني مختصرة. يعني عندي حوالي 14 باتنت يعني براءة اختراع. عندي أكثر من 80 يعني publications يعني.
ما شاء الله دكتور أحمد شنة، لدينا الشرف وخاصة الطلبة أن نتعرفوا على باحثين جزائريين الحمد لله ناجحين، ولو كان في الخارج إن شاء الله هم يكونوا ناجحين في الجزائر إن شاء الله الجيل هذا.
إن شاء الله إن شاء الله.
تسمع فيا مسيو أو نسمع فيا لما إن شاء الله.
وين نسمع فيك؟
تفضل أستاذ مسيو شنة، تقدر تبدأ الآن المحاضرة.
أوكي. Let me share with you my presentation.
وين كاينة بلوس؟
راكم تشوفوا فيها يا أخي ولا لا؟
احنا نشوفوا فيها كيف. دونك جوست فوالا تري بيان.
صافا؟ استني برك ندير الوحدة. بوينتر. اوكي يا اخي معليش نتكلم بالانجليزي معليش.
تكلم كيما تحب. طلبتنا نورمالمون يفهموا اللغات في كلاسات
صح
ان شاء الله.
صح.
حاجه اللي ما يفهموهاش نسالوك.
معليش اوكي.
اخر استاذ شنا ولا نقدروا نقاطع؟ من الافضل نسالوا من الاخر، سجلوا الاسئله ونسالوا هكا من الافضل.
أو طبعا احسن في الاخر، لانها المحاضره تكون حوالي ساعه، وفيها يعني 3 يعني 3 فيديو صغار، يعني ربما دقيقه كل واحد ولا دقيقه ونصف يعني. اوكي. اوكي المهم السبجكت هذا is very يعني is very wide and broad يعني so that it is difficult to really to put it in one presentation, but I'm going to kind of giving you a little bit of each. So okay, so the title is Current and Future Cancer Drugs. So this picture I'm going to ask you, this is a question for you now. So remember this picture, and I'm asking you from where I got this picture. So, so anyway, this picture represent kind of some people doing research in the lab. You see different medication, different types of medication here. So, and this is a microscope. So this is a research environment. So later on, we'll come back to it. Yeah. So, so there are. So my talk is going to be. I'm going to give an introduction about the cancer, traditional chemotherapy, targeted therapies, then immunotherapy, personalized medicine, and emerging trend and future directions. So as you know that this is the, for example, some statistics from the World Health Organization about different cancers, for example, the death. This is the not infection, is the death. So when you look at per year, you know, is about the biggest thing is lung cancer, for example, is because lots of men are around the world, they still smoking. This is because of the smoking. If they stop smoking, you know, this number will be lower. Then colorectal, you know, then stomach. Stomach, for example, is high in Japan, for example. Breast cancer is about 10% around the world. You know, different, you know, pancreas, for example, it has more than 95% of people who have pancreatic cancer, they die anyway. So because there is no medication for it, you know. Prostate is a very slow cancer. Even people when they are in 70 and 80, they get it, they don't die. They die only after maybe after 10 years or 15 years. So it's very slow cancer. So it's less problem. You know, the biggest is for women, at least breast cancer. For men, majority is lung cancer and colon cancer. So when you look at, for example, with diagnosis, for example, from 1975 to 2019, for example, when you look, for example, on lung, for example, lung, this is the red is going down, for example, diagnostic, because in the West now it's very difficult for you to smoke. In US, for example, or Europe, you cannot smoke only in the street, you know, you cannot smoke in any place inside, you know. So it's going down, for example. Breast cancer, for example, this is for female, for example, it's kind of stable around very close to 10%. However, that in the West, that when women get breast cancer, is tend to are detected earlier and treated, you know, and less death from that. It's different than the kind of the third world countries, you know, they discover it only later. And also there is no culture of going to the doctor, woman, I think after 45 years, they need to do mammogram every year or every second year. The one that they have their mother or grandmother, they had breast cancer, for example, they need to be screened every 6 months, for example, here. They need to do also genetic tests. They need to know if they have a BRCA1, for example, mutation or no. Because if they have BRCA1 mutation, for example, 85% chance of getting breast cancer anyway. So this is some statistics between men and women, just to know. But when you look at the risk, for example, of cancer, for example, the highest is, you see it is smoking. Yeah. Then also the excess of body, for example, this is body weight. Then the people who are overweight, they tend to have also cancer. Alcohol consumption, ultraviolet, especially for the white people, you know, European people and American, and so exposure to the sun a lot is not good for them because there is a DNA damage called the thymidine dimer is formed and causes cancer. Poor diet, of course, and others, you know, and less activity, also less physical activity. People are very active doing sport every day and active walking. they have less chance to have cancer. This is just how the cell is divided and how mutation is causing cancer. For example, you have a normal cell. Normal is divided in two. For example, if one, let's say this one has exposed to chemicals or radiation or anything and give you a damaged cell which has a one mutation, for example, what happened, either that it will die, apoptosis, it will die, or if this one, for example, keep dividing, mutation from one mutation to two to three, four, then become unrepaired, then it will lead to a cancer. Because mutation, there is a system that in the cell that will repair certain damage, but if damage is not recognized by our enzymes, our proteins in the cell, if it's not, they call it persistent damage, that means that it's not repaired. So it will lead to a cancer. Sorry. So what are the common treatment for cancer? So there is a surgery, for example, chemotherapy, radiation therapy, targeted therapy, immunotherapy. So I'm going to talk here about just chemotherapy and targeted therapy and immunotherapy. So when we look back at the chemotherapy is the first, in fact, the first method which started in the early 40s, for example. So chemotherapy attacked tumor at the cellular level, interrupting the process and substance for cell replication in life. So try always this, the chemotherapy, try to stop the cell from replicating. However, that the problem chemotherapy attack also the healthy cells, because we have healthy cells replicating in the body. It's like the hair, for example. You have hair, the cells are always replicating because the hair is growing. So that's the reason why the people, when they take chemotherapy, they lose their hair, because it's attacked by this chemotherapy. So when we look at the history of chemotherapy, for example, the era started in the 40s, for example. The first administrative, for example, is they call it is nitrogen master to patient with lymphoma. Nitrogen master, for example, is used as a gas, for example, in the war before, so which is toxic. It is really toxic. So that's the reason why the old chemotherapy, when they treat the people with the old chemotherapy, the people really are kind of, they don't have any energy, are kind of destroyed. So this is kind of different classes of chemotherapy. There's alkylating reagent, alkylating agent. This is taxanes. Taxanes are like, they came out in the 90s, for example. Taxane, toxotron, there are a group of these. They found them in a plant. This is different inhibitors, for example. Platinum complex, which is known, cisplatinum, for example, it is used for lung cancer and different cancer, for example. This is anthracyclines. Anthracyclines is a big molecules. They have multiple ring, for example. This is anti-metabolites, so it will target certain steps in the process here, for example. Tubulin, it is in the cell, for example, anti-reactive agent. This is other different types, for example, are available also. When we look at the structure, for example, this is alkylating. What does it mean, alkylating agent? That means that go and alkylate, create a methyl a group or ethyl a group in the basis of DNA. That means it damage the DNA. If it damage DNA of the cell, that means that the cell will not replicate. This is platinum. This is cisplatinum, for example. It's a famous one which is used a lot. This is kind of other derivatives of this. You see this molecule is here, but they added here different set of molecules. This is analogs of the nucleosides here, for example, are also drugs are used. Yeah. So I'll give you an example. For example, what is the alkylating, for example? This is an nitrogen master. They call it also BCNU abbreviation. BCNU, what it does alkylation and also form a cross-link. What is a cross-link? You have two strands in DNA, one here, for example, and one here. So it form a cross-link. See, this is a cross-link. That means that this cross-link, this DNA will not let it replicate. The cell will not replicate if you have a DNA. The two strands are connected to each other. So this is the cycle of the cell, for example, in cancer, for example. You have a normal cell, for example, here. So here it will, what it does, it will duplicate the chromosomes, become double here. Then here a chromosome will align. Then here will separate, you see separate them. Then here the cell separate in the middle. Then you have two cells. So when they develop, for example, a drug, for example, they make sure that is going to attack certain steps in the process of multiplying the cells, because the cancer the cells are multiplying very fast. So they need to control that. If they don't control the cell when it is multiplying, the cancer will go to another places and get bigger. So, for example, this diagram, for example, tell you this is different drugs, different medication that attack in different steps of the cell division. For example, there is the S, this is the G1, this is G2, the M. So there are 4 steps in the cell division, and each drug attack in certain step. So as you know that the side effect, there's a lots of side effect in the, they have hair loss. See this young lady with, she lost a lot of her hair because she is taking chemotherapy. So there is lots of trouble breathing, mouth sore, hair loss, pain, so many things because the chemotherapy is attacking everything, all the cells, So then in the 90s, 1996, 1997, a new field started. They call it targeted therapy. What is targeted therapy? They are trying to create a molecule that go and target only the cancer cells, does not go and target the healthy cells. So this is our antibodies, like the one that for breast cancer, for example, for HER2, for different diseases. You will see how it works. Okay, you have this antibody. Antibody is a big molecule. The molecular weight about 150,000, 160,000 is IgG, for example. This is kind of the structure. That has Fc. You have the FB, for example. This is the top. They call it F. Fab. This is FC, for example. So the PEEP and has also the disulfide here, disulfide. You can cleave it here, you can cleave it here, you can cleave it here. And later you will see they can play with it a lot now. What it does, you have this area here is very specific. It go and only attack the cancer cells based on the protein overexpressed on the cancer cells. So what is the difference between traditional chemotherapy and antibody. For example, traditional chemotherapy damage healthy cells, rapid clearance. That means that the person, when is treated with this, the body will clear it fast. Antibody, for example, has high binding affinity, specificity for tumor cells. It go only to tumor cells, and also long life. That means that when they inject the patient, you don't need to give that patient every day this medication, for example. So how it works? So as I have seen this is antibody I told you. So you have the cancer cells. What happened? Cancer cell. Cancer cell has, this is a protein which is overexpressed here. This is a protein, for example. That's a protein overexpressed. They call it antigen outside the cell. So the antibody here come and stick to that one. Then will work to damage it, to kill the cancer cell, only based on the protein overexpressed. This antibody is very specific. It does not go to other cells. So the first, or kind of the second really antibody drug was approved by FDA, was Herceptin. Herceptin is used for treat very aggressive breast cancer, for example. And how the doctor, for example, decide about to give Herceptin, for example, to so what happened? They take a piece. They take cancer cells tissue from the patient, and they do immunohistochemistry. Immunohistochemistry, and what they see. You look at this one, for example. This is like HER2, for example, 0. This is +1. This is +2. This is +3. So all the patient with the +3, they will be treated with this drug, The one that they are +2 or +1 or 0, they are not. A +2 here, they will do more tests for them. Another one, they call it FISH or ISH, to make sure that either that they will give them that medication or not. So this is a short video.
Coursing through your blood right now are immune molecules called antibodies. Antibodies protect you from a number of threats, like bacteria, viruses, and even cancer. Antibodies can also be made in the lab and used to treat cancer. These are called monoclonal antibodies. Antibodies have a distinct shape that allows them to bind to precise targets, called antigens, which they match like puzzle pieces. Antigens are found on the surface of harmful invaders. By binding to an antigen specifically and tightly, antibodies mark their target for destruction by the immune system. Monoclonal antibodies used to treat cancer work the same way. The drug Herceptin, for example, is an antibody that binds to an antigen found on breast, ovarian, and other cancers. Immune cells see Herceptin bound to this antigen and engulf the cancer. A second way that Herceptin works is by blocking a needed growth signal. Without this growth signal, the cancer cell starves. Herceptin is just one of more than a dozen monoclonal antibodies the FDA has approved to treat different forms of cancer, including stomach cancer, colorectal cancer, lymphoma, and leukemia. Created by the Cancer Research Institute, a leader in immunotherapy. To learn more about immunotherapy and about clinical trials, visit our community for patients and caregivers. Coursing through your blood right now.
So did you hear that video?
Yes.
Okay. So, okay. this is okay. This is, for example, just look here. Let me show you this. Anyway, so on the right hand side, for example, you see, for example, how many FDA has approved different antibody based drugs, for example, from 1986, for example, started going up. You see the list now is going up. This one are in for cancer, for example. Let me see the pointer. Okay, yeah, this one, for example, for cancer, you see it. So other diseases also it is used now. So this is kind of a list, is not, because I cannot fit the whole list in one slide, you know. So for example, one which has made a big revolution is the one, this is the Herceptin for 1998, for example, for breast cancer. There is others, you see, till anyway, till this year, there are new one, but I need more. I need another slide just for another set of them. So this is a kind of what type of cancer can be treated, you know, as a different cancer: brain cancer, breast, colon cancer, head and neck, lung cancer, melanoma, stomach cancer. All can be treated with these now. The big problem with these, kind of expensive for countries, you know, in the third world countries, they are really expensive medication. So now I'm going to talk about different one. They call it EDC. EDC is okay. After when they made these antibody-based drugs, what happened is that they try to improve them, to make them more kind of more efficient than before this antibody based. So what they did, so they took this antibody. Look, this is antibody that I showed you before. They created with it a linker, for example, and a drug. And this drug, this is kind of very toxic drug. This drug, if they give it to a person, will die. A person will die. But I will show you how it works. They call them EDC. So the EDC is antibody drug conjugate. That means that you are mixing, you have a drug linked to an antibody. So this antibody goes to the cancer cell. How it will work? The first, it will be binding. Then they call it internalization. It go into the cell. Then degradation, then release, then it will kill the cell. Let me show you how it works, the mechanism. So you have, this is cancer cell, for example. So there is overexpressed protein here, let's say. So this is the drug EDC that has antibody. It has also this red one is the toxic molecule. Stick here to it. Then the cell, what it does, this internalization, it will swallow it. It go inside the cell. When it is inside the cell, what happened to it? It will be cleaved. This will be cut. So this toxic molecule, it kill the cell. So let me show you. This video.
Recent oncology breakthroughs. Conventional anti-cancer treatments may have limitations. Decades of dedicated research are resulting in the capacity to create a new generation of antibody drug conjugates, or ADCs. Can an ADC be greater than the sum of its parts? An ADC is a unique combination of a targeted monoclonal antibody, a stable linker, and a potent cytotoxic. They are designed to deliver anti-cancer agents directly to the tumor cell in a targeted manner to limit systemic exposure. Based on preclinical studies, the monoclonal antibody component of the ADC binds to the target antigen on the tumor cell surface. Target antigens are preferentially or exclusively expressed on the surface of cancer cells to provide a tumor-specific binding site for the monoclonal antibody. Monoclonal antibodies have the ability to persist in circulation over time, allowing for prolonged exposure to the cancer cells and to become internalized by the cancer cell. Stable linkers conjugate potent cytotoxic agents to monoclonal antibodies and are designed to allow ADCs to remain inactive while in circulation. Linker stability in circulation controls the distribution and delivery of the cytotoxic agent to the target cell. The use of more stable linkers may allow delivery of the cytotoxic agent to the cancer cell over an extended period of time. Cytotoxic agents incorporated into ADCs can be up to 1,000-fold more potent than currently used drugs. ADCs are designed to allow for the use of highly potent, normally intolerable anti-cancer cytotoxic agents. ADCs have multiple proposed mechanisms of action that represent a potential therapeutic approach. The monoclonal antibody component of an ADC may possess its own anti-cancer activities, which may include prevention of signaling, antibody-dependent cellular cytotoxicity, ADCC, and induction of apoptosis. Upon binding to the target antigen that is preferentially or exclusively expressed on the cancer cell, the ADC antigen complex may be internalized through a process known as receptor-mediated endocytosis. Based on preclinical models, internalization of the ADC antigen complex is followed by lysosomal degradation of the complex, resulting in release of the potent cytotoxic agent. The cytotoxic agent then interacts with critical cellular machinery to elicit cell death. Antibody-drug conjugates, ADCs, are under investigation in many different cancer types. The potential of ADCs has been enhanced by several factors, including a more clinically relevant choice of target antigens, more potent cytotoxic agents in conjugation with linkers of improved stability, and a greatly expanded knowledge of ADC technology, cancer biology, and pharmacology.
Okay. So, Kima, so what is important here is when you have the antibody is the cytotoxin here, and also the linker need to be cleaved when it go into the. So the antibody is the primary. The linker is this is pink one. Then they call it the warhead. You know, the one that kills the cell. This is the kill the cell. So this is some of the linkers, for example, that what happened, the linker, when it get into the cell, it will be cleaved. This is protease sensitive, for example, and the cell will be cleaved. This one will be cleaved. This one is acid sensitive, hydrazone. This one is cleaved in the cell, for example, because they have the antibody here, you have the linker, you have cytotoxin here. So also here, for example, this is as for example, disulfide. It's cleaved also by glutamate, this, for example, in the cell. This is, for example, a list of drugs that EDC has been approved, for example. The first one approved in the year 2000, for example, and this is only the list till 2021. There are more which approved the last 3 years, for example. When you look, they are targeting different, different things, from HER2 for cancer, CD30 for different diseases. So this is, for example, some example of EDC, for example. This is already, they are in the market for the last few years, these drugs, for example. This is the structure for example, for Cadila, for example, this antibody, you have the linker here. Then this is the warhead, which is the kill the cancer cell when it gets in, for example. This is another one, for example, brontuximab, for example. It has very long, this is a peptide linker. This is a peptide linker. Aristatin, this one molecule. This is the warhead. So that's about the kind of the antibody based. So I'm going to talk now about immunotherapy. So immunotherapy is biological cancer treatment that boosts the body immune system to fight the cancer. So your body immune system detects something harmful in the body, kind of unusual, and the body starts fighting. So what happened in the last few years, they start using, can we educate our immune system to fight more the cancer cells, for example. So there are different ways of doing that. So as we talked about traditional cancer treatment, so like say radiation or medication, for example, it's going to kill, like chemotherapy, it kills the healthy cell and also cancerous cell, for example. But immunotherapy, for example, what is going to do, it boosts the immune system of the person, and it kills only the cancer cells. So there are less, of course, there are less side effects. For example, I didn't mention that the side effect of, for example, for this type of this is very minor side effect. People, they don't lose their hair, for example. They will be itching, in their skin, maybe. So they are a small thing, it's not like chemotherapy. Woman, for example, or man or woman, doesn't matter. They will lose their hair, their immune system will be down, they cannot eat, they are very weak. So I know a lady here that she had really stage 4 breast cancer. Stage 4 is very advanced. And she was treated with Herceptin and lived after really more than 10 years. More than 10 years lived with it. Yeah. So this treatment really is making a change in life of lots of women. So immunotherapy, there are different types, So there is a cell therapy, which is they call it CAR T cells. I'm going to talk about that. I'm going to show you how it works. For example, immunomodulator, for example, which is a cytokine, use cytokine. Also, they can use also some oncologic virus therapy. They take lab, for example, modified viruses, and these viruses really go and attack the cancer cells. Monoclonal antibody, I showed you, and I will show you more about that, which there are different types of antibody on the body. They will kind of teach them to fight. Cancer treatment for vaccine, there are also some vaccines are in development. Here, vaccine does not protect you from the cancer, but what it does, it will go and improve your immune system to attack cancer that already you have. So this picture, in fact, represent, there are about 6 types of immunotherapy, kind of cytokine, for example. The body when releases all these, against the cancer cell to kill, for example. PD-L1, which cancer cell that they overexpress PD-L1. So there is a drug for the PD-L1. PD-L1, it made a lots of, when you go and Google it, PD-L1, you will find over 1,000 papers about it, and it is used a lot for as a treatment. So as I told you, cancer vaccines, for example, that's targeted based on the tumor specific. There is a chemokine, for example, T cells recruitment that will also attack the tumor cells. So there are different types. This field is very broad. If you want to really, I have a friend who has been working on this for last 20 years. If you want to have just a presentation about immunotherapy, I can give you his name, and he's well known in the field. So this is, for example, FDA, for example, immunotherapy drugs for different types of cancer, for example. When you notice, see, this is target PD-L1, PD-L1, I told you, VEGF, because the cancer cells, they overexpress sometimes VEGF, PD-L1, see HER2, different targeted. This is the target that they are going to, yeah. So how for example, the antibody, for example, how they do. So this antibody, for example, before I showed you antibody target only one thing. There are now antibody target two things or three things, in fact. This, for example, this antibody, for example, this one is anti-PD-L1 on the top, but here is anti-CD47 binding. So it binds to two sides, yeah. Some of them even bind to three sides of different cells. This is two cells. How, for example, they give, for example, the patient, for example, a drug which anti-PD-L1, for example. What they do, for example, this is a picture from my lab. If I could, we do immunohistochemistry from the cancer cells, and you see this is a brown. This brown are because of the PD-L1 on the cancer cells. You see a black here, yeah. This is the lung cancer, and this is breast cancer. You see it here, for example, is black, yeah. So these two patients, for example, they can be treated with PD-L1. So for the last few years now, making really different antibody-based drugs, for example, or from different size, different targets, till even the nanobody. The nanobody, in fact, was discovered by a professor from Belgium, from La Belgique, for example, at least over 20 years ago, and he found them are in the camel and Vijmel. So now they are using them. They are very small and very useful, very small and very useful, because the size is very important sometimes. So now there are lots of engineering to make, parts of the antibody that you want what you want. For example, this is triumab. That means that can target three parts. This is a quadroma. That means that even four targets at the same time, not only one target or two targets, 3, 4. So this is example, for example, of antibody that target two parts. So you have a cancer cell, this one, for example, CD19. And this is CD3 receptor. For example, here, on T cell. This is a T cell. This is a cancer cell. So T cell will kill the cancer cell, but how you bring them together? So you have this antibody, this one, this anti-CD3, for example. So they take this part, this is dark brown here, and this one anti-cancer cell CD19. They take this light brown. They take this one, and they combine them. They can make this one with two parts only. So, and this, what it does, it will go to the cell, and in one side will stick to the cancer cell, one side will chill, the T cell. When it is stick together, what happened? The T cell will release some proteins like cytokine, and will kill the cancer cell. That's how it works. I'm going to show you here. Let me see.
Blinatumomab. Blinatumomab consists of two single-chain variable fragments where one binds to CD3 and the other binds to CD19 with a flexible linker between them. This biprotein can connect a T cell and a CD19 tumor cell or a CD19 B cell by simultaneously binding CD3 and CD19. When both single-chain variable fragments bind to their target antigens, T cell activation is triggered, which leads to the release of cytotoxic granules, cytokines, and T cell proliferation. Lysis of the tumor cell or B cell involves membrane perforation followed by programmed cell death induced by granzymes. Bites trigger serial killing by activated T cells. Approaches to limit adverse neurologic events caused by blinatumomab treatment include the blocking of activated T cell migration into the CNS through PPS treatment or the reduction of cytokine activity through the use of corticosteroids such as DEX. What cells blinatumomab may recognize in the CNS is unknown, but the adverse effects resolve when treatment is discontinued.
So, so the other part, which is immunotherapy, this is CAR T cells therapy, which is, it's very important. What they do here, they use the T cells from the patient. Okay, you have a patient here. They take the T cells they take blood, then they separate the T cells. That's before any chemotherapy or any treatment. So they take this, okay, the red cells, and remaining from the blood will go back to the patient. They take this one. What they do, they modify them. They modify them based on the surface. They will be more specific. So when you have this small number of T cells modified, it has a specific receptor, and they grow them in the lab. They become millions of cells, okay? Millions of cells. So the patient will be treated, let's say, with chemotherapy, let's say. Is given before they put these cells back. Then the person, after, let's say, a week or 2 weeks, start recovering. They put these cells again to the patient. So these cells, they will be fighting the tumor, and the person will recover. So kind of you are educating the T cells, making them more efficient for that specific disease. Because if you put chemotherapy, if you treat a person with the chemotherapy, you will kill all these T cells. So you take them before, you modify them, they become more specific, then you inject them again. So they will fight. Okay. So let's talk now about RNA vaccine. As you know that RNA during COVID, for example, create a revolution for creating a vaccine, for example, for COVID, for example. Pfizer did it, Moderna, a few other company, which is now make it fast to create a vaccine for viruses faster in a few weeks. Not a few weeks to design, just the design and testing it. So for cancer is not, in fact, this vaccine will not protect you against the cancer, but it will help you fight it. So what is the advantage of this vaccine, RNA vaccine, for example, in the context of therapy? You need less time, in development, rapid production, highly targeted, lower cost, fewer side effect, lower risk of intersectional mutagenesis, for example, support personalized medicine because based on the type of the cancer of that person, lower risk of viral infection. So it induce a stronger immune response. And how it works? This is the mechanism how it works. You have messenger RNA, for example. It go to the inside the cell. Okay, you have RNA, so it will make this protein. This protein can make the T cells, for example, for example, it continue this will become and create this MHC receptor. This receptor, for example, interact with the T cells and B cells. Then when they interact, they release the cytokine and they kill the tumor cell. So this is, for example, ongoing clinical trial. This is still in clinical trial. When you look at this phase 1, phase 2, phase 2, so it's still not in the market yet. I'm just telling you, it's still not in the market. It's still in clinical trial. That means that it's still in testing. Personalized medicine, for example. The other part, personalized medicine. Personalized medicine is tailored, based on the patient, based on the genomic profiling and the biomarker identification based on the patient. Because from patient to another patient, they are different. Let's say you have breast cancer, for example, since that you are most of you are women. Breast cancer, for example, there is, AR positive, PR positive, HER2 positive, there is triple negative, at least four types of breast cancer. So each type is treated different based on the genes of that person, based on the proteins overexpressed on the tumor cells. So the treatment is based on the genomic and biomarker, which is a protein. So clinical trial and personalized approach. I'm going to talk about emerging trend. That means that the future directions of the treatment. What is the future treatment? Combination therapy. What is combination therapy? That means that the patient will be treated with multiple things. like from maybe some radiation, some maybe chemotherapy or antibody-based therapy, a few things together, trying to slow down the cancer so a person can live with it. Because other diseases, let's say I give you HIV, SIDA, for example. 30 years ago, for example, SIDA, 1986, when it started, 85, I think it started 82, exactly. So people dying, they die from SIDA. But now people, they don't die. They have SIDA, but they live 30 years. Why? Because multiple drug treatment. There is no cure for SIDA, but صح كاين. There are multiple drugs. What this drug does, they study the virus very well. So each drug will slow down the replication of the virus. They control the virus. So now, for example, people that have SIDA, they take a pill, pill, حبة عدوى فيها 3 ولا 4 أدوية مع بعضها. Because before what they do, for example, a person will take 4 or 5 pills. But now companies, they decided to make it easier for these people, for example, to take only one pill, has everything. And now the people are living with HIV, for example, or you can go to other disease. So, but cancer is not yet that you can live with cancer for only prostate cancer. You can live with it for 10, 15 years. But other cancer, if you have cancer, either that you have to treat it to get rid of it, or will kill you. There is no chance. So now they are trying to, is there any way to slow down the cancer and people can live with it, let's say 20 years or 30 years, Let's say if someone who is 60 years old or 70 years old, question is, if they get cancer, they will die in a year or they die if they're going to die in 20 years, doesn't matter. 70 plus 20 is going to be 90 anyway. Is going to die, even if he's not going to have cancer. So combination therapy is going to hopefully kind of attack, cancer in different ways, Another thing, which is drug delivery. Drug delivery is a big problem for brain cancer. Brain cancer. Brain cancer is the drug does not go and penetrate the cells in the brain. Because the brain, it is made with the barrier between the cells, that chemicals does not get into the medication, doesn't get into the brain cells. In order to protect it, I think God created that maybe, but it is big challenge for people with the brain cancer. They don't last, they die. Because, so there is now lots of work now, it is done now to improve the penetration of the drug in the brain, for example. Artificial intelligence in cancer research, for example. Now, AI, artificial intelligence, now it is used now for designing a new molecule based on a whole history of cancer molecule has been tested before. One worked, one didn't work, which one worked. So the system, artificial intelligence, can handle lots of data. So now a drug design, there are lots of artificial intelligence now, it is used for drug design. Another thing which is very important for treating patient is some people, after a while, when they are taking drugs, they start having drug resistance, So So drug resistance is a big problem. For example, for antibiotics, for example, people are taking lots of antibiotics. Very often they create antibiotics resistance, for example. So it's very difficult, you know, for them to, when they have a disease, to find them the right antibiotics to really cure them. So also drug cancer also create kind of resistance, you know, body will try to resist this type of molecule. Yeah. I'd like to thank you for your time and your for attention. And now you can ask me any questions.
Thank you very much, Dr. CHENNA. So we pass to questions. Bon, on commence par les étudiants de M2. Je vais choisir aléatoirement pour vous forcer. Même si quand vous demandez à expliquer une chose. Amina, question. Quand même. On appellera la voix pour poser la question. Allez, vas-y, pose la question. Les étudiants de M2. Et voilà, on a étudiant de M1 Zakari, donc il va vous poser une question. تقدر تجي هنايا عند الجليلة باش يشوفك بك الكويشنة ولا الكويشنة تشوف الطالب اللي راح يسألك.
ما يهمش هنا، المهم نسمع السؤال بركة واضح برك.
سؤال تقدر تسأل سؤال.
بصح لازم يجيب حذاك بالك باش يقدر باش نسمعوا بيان.
تفضل هنايا هكا بك باش يشوفوك وباش تسمعوا مليح وخلاص.
يا باه نسمعوا بيان.
As you said before, antibodies attack only cancer cells, but how can it see the difference between healthy and cancer ones?
Oh, because okay, the antibody is when they make it is made based on very specific overexpressed. Let me I'll go back to explain to you how it works. So, okay, do you see this one? So this is antibody. Okay, you have cancer cell, okay? Cancer cell, we know it overexpress. That means, what does it mean overexpress? That means that it's making one protein at least a lot overexpressed. That means that, and you find it on outside of the cell. This red, let's say, look at this red one. This is a protein, it's made on the cancer cell, but the healthy cell, you don't find this one, okay? The healthy cell does not have this triangle protein, red one. So when we make antibody in the lab, for example, a specific for this cancer, for example, breast cancer, for receptor, for example. So this side of the one interact with the cell, it has very specific sequence that interact only with this one, does not interact with the green one or this one. So if you have a healthy cell doesn't have the red one, the antibody will not stick to it, will not go to it. فهمت دركا؟
Détecteur de protéines.
Yeah, it detect only the overexpressed. I said overexpressed, that means that cancer cell, they make a lots of certain proteins. I'll show you. For example, look at this one. This is all cancer cells, okay? What we do, we cut it, we color it with different things, we put certain antibody. Here we put anti-HER2, for example, HER2, okay? This one, for example, is blue, does not have, this patient does not have any HER2, you know, overexpressed. Here is very little, here a little more, here a lot of it. See, See the cell and surround with the brown. This is brown, or yeah, that's HER2. Yeah, which is stick on it. Yeah, the HER2. Yeah, that means that this is very specific for this one, because this one, the same HER2, we put it here, but you see it's blue. That means that you don't have it. So it's very specific. This side is very specific. The sequence, what we use, what they do, they take this protein, for example, they sequence it. They find out the sequence, the peptide is made of what? From that, based on that peptide, they take and they make this one for it. Is it clear for you?
Yes.
Oui.
Okay.
Question, l'autre question. عبد الرحيم تفضل باش يشوفك.
I have two questions.
Première question.
Why the cell when divide one from of them is damaged, became damaged cell. When the cell one cell divide,
Yeah.
one cell is not damaged, but the other is damaged. Why is damaged?
Je crois que début place la
Yes.
deuxième.
You mean how when I showed how the cancer started?
Oui,
Yes.
هنايا.
What make the cell damaged?
Damaged?
Yes.
Okay. Okay, the cell can be damaged by we are exposed to lots of things. When you go outside, you are exposed to the sun. Okay, for example, the sun can create damage to your cell. What the sun create a dimer called thymidine dimer. Okay, you are exposed to chemicals. Let's say someone is painting your house and you go there and you smell bad smell because of the chemicals. That chemicals go inside your body and can damage you are eating, for example, food with pesticides, for example. Some pesticides will, and some chemicals also will damage, you are exposed to, and will damage your DNA, your cell. If your DNA is damaged and it is not repaired, what happened? When the cell replicate, it will create a mutation. That mutation, if it is not repaired, it will divide again and create 2 mutations, 3 mutations, 4 mutations, then become out of control. So there is a big field, and I worked for it for 9 years. They call it DNA damage and repair. Go and Google it, DNA damage and repair. And you will find, I give lots of presentation about it, just DNA damage and repair. Yeah.
Deuxième question.
mRNA vaccine. When the human takes it, did he will protect him from the cancer, or potentially, just potentially?
Okay, is not. I said is not a protection. It used for the people already they have cancer. This one. So what it does, it will help your immune system to go and kill the cancer cells. But it will not, this is not a vaccine that like for COVID or other will protect you. Sorry, I said, yeah. What it does, it is just to protect you, not to protect you, help your immune, introduce here. The purpose is to introduce stronger immune response. That means that will activate your immune system to kill the cancer cells. It is not protecting you against the cancer before it starts. No.
Mhm. Thank you very much. Manal, une autre étudiante de M1.
I have two questions. What are the most effective treatments for brain cancer?
Oh, that's I think brain cancer is just
اسمك
very challenging. You know, very challenging because brain cancer, the brain barrier, so it is very difficult to penetrate. The small molecules, for example, drugs, they tend to difficult to penetrate because the brain is trying to protect itself from all toxins, you know. So there is now some companies, what they are doing, they are taking the antibody based drugs, for example, and they are changing them. They are changing them, tweaking them to make them go into the cells in for example for Alzheimer, for example, for Alzheimer, because it's something related to the brain exactly. So they found that because now there are 2 drugs now available for Alzheimer to slow down the Alzheimer by about 30%. So company came and found that, okay, if they can improve the penetration of these drugs to into the cells, it will help. So they started, so they call this company, name is Denali. So I attended 1 or 2 presentation for them in the conference. So they are modifying the antibody a little bit, you know, to make it more accessible to the, yeah. So it is challenge really. I know some people. I know someone who was with. I know him when I was a little. So he got brain cancer and died. So yeah, it is a lots of research. It is going on that. What is your second question?
How long they will take for remove this cancer from brain?
Oh, I think that it is based on the size, based on the size, based on the size and the drug, you know. So so what they do when they start treating that patient, then they will do, you know, kind of either PET scan or MRI, and they need to just keep seeing if it is shrinking or no. If it is shrinking, they will continue. If it is not shrinking, it's just no need really to treat that, you know, or they need to change different drug because this thing is based on the person, you know. So there, yeah, based on the dose, you know, based on the size, based on so many things, you know. No one can tell you, oh, you need to be treated, you know, 1 month or 2 months or a week, because you need to really see exactly, you know, the size of the tumor really. And some people, they are sometimes, if the tumor is not in a place where it's very sensitive, they go and they operate on it, you know. I know a lady many years ago. She was working in the same building where I am, and she got I think brain cancer, and she had operation, and they operate on her and they remove the brain tumor, and she survived. She survived that.
Ok. Une autre question. سندس تفضلي. كل يعمل d'autres questions باش توجدوا روحكم. تفضلي سندس.
How exactly does the artificial intelligence help treat cancer?
So the artificial intelligence now is kind of used for a couple of things, like diagnostic, for example. Let's say you have what they are doing now. They are teaching systems, to detect, very early cancer. Let's say when you have a doctor, for example, or radiologist, have lots of pictures, for example, to see, their eyes, get tired, So now they are kind of teaching, for example, using artificial intelligence. You teach it first, you have lots of data. You tell the kind of the system what are you trying to detect exactly, and they start they create a set of teaching, then a set of testing. Then when they found it is more than 90, let's say 98%, 99% correct, so they can use it. They can use it for detection, early detection, small thing. And also they are using it for designing new drugs, so to become more efficient and less side effect has in it. Yeah. So that's the only two things, for diagnostic purposes and also for creating new drugs.
Une autre question, docteur CHENNA.
Okay,
Please.
no.
Please, what are the potential challenge or limitation of this new treatment?
The potential challenges, I think, for the third world country, I look at it when I think about Algeria or African country or Asian country, these new treatments are very expensive. For example, Herceptin, for example, is about I think more than 30,000, $30,000, $50,000, treatment. $50,000 is صورة تاع الجزائر أكثر من مليار تاع الجزائر. Donc it's very expensive. But in the West, the insurance, pays for that people they have insurance, so they can get treatment, even the people they don't have insurance. When they go to the hospital, they cannot say to them, okay, you don't have insurance, you will not be treated. Yeah. So I mean, this new treatment is much better than old treatment anyway, less side effect. People are living longer with cancer, and lots of people are kind of, when you detect cancer early. Me, what I can tell you, I mean, especially you girls, you should really teach your sisters, your mothers, your aunts, خالاتكم, عماتكم, to do a self-test at least once a month, for breast cancer, So not only wait till, start, feeling something, you go to the doctor, said, oh, you have already, kind of very late stage or something. A woman does, once a month only, self-test. I think the University in Algeria, they should really have a class for women, for all the girls in the university, to teach them how to do a self-test for breast cancer, really. And they can go and they can teach their sisters, their mothers, عماتهم وخالاتهم وجيرانهم. I think lots of people will be really saved.
Inshallah. Une autre question, one another question.
I just want to know which one of techniques therapy is very efficacious and useful for now.
What technical therapy? Which
You've لي تكنيك اللي ذكرتهم ديجا.
You know, antibody based therapy is it has less side effect. That's more effective because it go and kill only the cancer cells. I think that's kind of the best. However, that we have to know that each cancer because when you look at the human, you know, we have different types of organs, you know. When you look at, we have so many cancer types, you know. When you look at this list, for example, you have brain cancer, you know, breast cancer, you know, leukemia. This is based on the blood. Colon cancer, head and neck, you know, lung cancer, melanoma. We have so many types of cancer. You cannot have the same drug for them. You have to know that because each cancer is different. Leukemia, for example, it is in the blood. You know, breast in the breast, the other one in the brain. So because they are different cells, so they have different overexpressed proteins. That's the reason why they have different antibody. There are some drugs are used in a few. Let me tell you. For example, HER2 is used for breast cancer and some colon cancer. Some people with colon cancer and stomach cancer, they overexpress HER2 protein. So some people with colon cancer, they are treated with Herceptin. And the same with the breast cancer. And the stomach cancer also is also they use it. But you have to make sure that there are the cells, when they take the cancer cells, they do immunohistochemistry in the lab, and they will show that there is overexpressed, for example, HER2 cells. Because they will not give you a drug here in the West without doing testing, you know? Because the drug is going to go and kind of attack that specific cancer, you know? So that's the reason why other diseases are easier to solve. But cancer, because they are different types. Each type, for example, I told you, breast cancer has only about 3 or 4 subtypes, you know? So what you do? For each one of this list, you have a couple of them. For example, even leukemia has at least 3 types leukemia. So that's some of them there are some drug for them, some of them are not, you know. Let's say for a triple negative breast cancer, triple negative, you know what does it mean, triple negative? They are not HER2 positive, they are not ER positive, not PR positive. They don't know even what type of drug they give it, you know, because they will just give it any drug here, you know. Triple negative, there is no treatment for triple negative at all.
D'accord, ok. Merci beaucoup. Une autre question, Monsieur Dr. Chenna. Taliba, Slimani, Rahma.
Can we use the nanotechnology to destroy the genetic information of diseased cell?
Well, here nanotechnology now it is not okay. A few years ago, what they did, they took antibody, and they connected with it a linker, and they put a nanoparticle, okay? And this nanoparticle, after when they give it to the patient, they tested it, for example, and when it reached the tumor, they shine the light. They shine, let's say, laser on it, you know? And that nanotechnology try to kill the tumor cells. So there are some research on this field, yeah. But I didn't see any drug which they are using now nanotechnology as approved or used, you know, routinely.
Okay, thanks.
You're welcome.
كوثر متشرفين بك الأستاذ شنة. سؤالي
شكراً.
بخصوص الأبحاث الجديدة اللي وصلوا ليها تاع يدوروا الأديان باه يعالجوا من السرطان بالكريستالوغرافي يدوروا الأديان. حبيت نعرف إذا كان فيها علاقة بالكيمياء العضوية. أنت أستاذ قلتنا في التخصص تاعك بديت بالكيمياء العضوية.
نعم، بديت بالكيمياء العضوية. كيفاش يدوروا الأديان؟ قولي لي، فهميني الساعة.
الكريستالوغرافي حنا عندنا شغل سبيسياليتي ولا موجيل في الفيزيك اون جينيرال. هما الابحاث الاخرى اللي وصلوا لها قال لك بلي لاديان القطعه اللي في لاديان اللي مريضه بعد لقاو فيها الخلل كما نقولوا حنا
اوكي.
يطوروها. هذه هي الحاجه اللي ما فهمتهاش واسكو فيها علاقه بالكيمياء العضويه. من كما كنت قاعد تحكي لنا انت البدايه اللي تما تاع العلاج هي من الكيمياء.
شوف، اوكي. ذوك اوكي كي يديروا كريستالوغرافي، let's say you do it. بصح الفورم تاع الكريستالوغرافي الوقت هذاك هو الذي في السيل انه ان ليكويد فورم، يعني فهو في الليكيد ولا لا. الاديان انه في السيليل يعني عنده دبل ستراند، يو نو، زوج كيما هكذا، يعني دبل ستراند in a solution، في سوليسيون. ماهوش انتم راكم ديروا لي زيتيد تاع كريستالوغرافي. نحن نديروا فور اكزومبل نديروا موليكيولار موديلين مثلا. كي تولي الدي ان اي دامج، عنده دامج مثلا، ونديروا له موليكيولار موديلين باش نفهموا قداش الانتربشن مثلا تاع الدبل ستراند مثلا، فهمتي قد يتحل. دونك ونعرفوا ثاني نديروا في اللاب ثاني ريبليكيشن، نديروا كيما كوبين كيما السيلول واش راهي يدير السيل، فهمتي. ونشوفوا هاك الموديفايد بيز، هذيك الموديفيكاسيون تاع لا باز هذيك. كي اسك مثلا عندك انت جي نورمال تولي قدامها سي ولا لا، والثايمدين فور اكزومبل تكون قدامه ادينين، فهمتي. الكومبليمنتير تاعو. ساعات عندك الوحده الدامج هنا هذيك فيها الباز عندها رياكسيون مع برودوي شيميك ولا هكذا. عود ما عندك ادينوين فور اكزومبل باش تجيها ثايميدين، تجيها مثلا سايتودين ولا تجيها جوانين ولا تجيها هذه كرييت، يقولها مس ماتش. هذا مس ماتش. هذا المس ماتش if it is not repaired كاينين دي بروتين في السيلول تروح ودير تنحيه وتركب فيه الوحده اللي نورمالمون تكون ثم، فهمتي. دونك السيستم تاعنا نحن في السيلول عندنا ريبير سيستم، فهمتي. عندنا ريبير تاع انزيم تدير هذيك الخدمه تاعها. لانه كنا ما كانش ريبير سيستم، هناك الواحد الانسان اقل بالك من 10 سنين يجيه الكونسير، لانك ديما راك معرضه للشمس ولا لا، معرضه لمواد كيميائيه ولا لا، من راك انت بيبي من لما تولدي. مثلا هنا مثلا هذه اليامات بكري نحن صغار في الجزائر يا اخي، الذراري الصغار يديروا لهم البودر ولا لا، تالك هذاك ولا لا. هذاك درك القوب اللي راهو يسبب السرطان هذاك. دونك جونسون اند جونسون هي اللي تخدموا الايامات بركه خسرت اكثر من 10 ملايير دولار لانهم دخلوها في الشرع. لانهم قالوا اوكي الجماعه اللي بكري يستعملوا التالك هذا بكري، ذاك الوحده البيضاء ذيك البودر هذيك البيضاء ذيك تاع الدراري هذاك، قالوا باللي راهو يسبب السرطان، فهمتي، يسبب امراض. المهم دخلوا الشركه جونسون اند جونسون في الشراع وربحوها وراح تخلص اكثر من 10 ملايير، بالك 20 ولا اكثر من 20 مليار دركا كومبونساسيون. دونك الحاله تاع الكريستالوغرافي راهي ما تمثلش اكزاكتومون الموديل تاع الصح كي تولي في الليكيد في السائل فهمتي؟
شكرا.
yeah.
Why does skin cancer attack white people more than people with color?
Can you repeat?
Why does skin cancer attacks white people more than people with color?
Okay. Skin, yeah, فهمت, yeah. This I don't know really why. Maybe the brown people, they have filter, you know. so they have a kind of, they don't need to do بلا ما يديروا وش يسموها هذيك الكريم هذيك ولا هذيك to protect them. So yeah, I really ماني اقول لك بالحقيقه والله مانيش عارف. You have to, you can Google it and you will find it, but yeah, the white people, they get, because they are, maybe the white people, European and the North, because they are not exposed to sun a lot. So anyway, they have a transparent skin.
Thank you.
Thank you very much. Do you have other questions, Ryan? Maybe a last question. Ryan and Hadi, نجمع ما عندكش question. إسلام question. شكون اللي ما عنده؟ هاي باش نزربوا برك. ولا حابين تروحوا بالبيسة 5. Ryan, question. طالبة ماستر ميديكال. تفضلي ريان.
What is the role of genetic factors in causing cancer?
Oh, there are a lot, you know. So for example, so let's say if the grandmother, let's say واحدة عندها جدها مثلا جاها breast cancer وأمها جاها breast cancer. أنا نعرف واحدة كانت تخدم معانا جدها جاها breast cancer أمها جاها breast cancer. راحت تدير تيست جينيتيك تيست لقيت بالي راهي she was positive BRCA1. That means that عندها chance of 85% يجيها breast cancer. راحت she removed her breast before the cancer started. So some people are when they have some mutations, even for colon cancer, there is a mutation which is very specific for that the people, when they have it, they have higher chance to get colon cancer. So yes, genes are important for certain cancer. That increase the chance. The people with certain mutations, they should follow the doctor. In fact, the people with the BRCA1, for example, they need to do mammogram maybe after, I think, they start maybe even 30 years old and every 6 months.
Okay, merci. Une autre question. Hadi Zagad.
After the antibodies stick with the protein of cancer cells, how can these antibodies destroy the tumor? What happened inside the cells?
Okay, what it does is, as I explained, there is internalization to antibody هذاك kind of يدخل في السيلين الداخل، لأنها السيل عندما تلصق فيها حاجة لبرا دير another step يسمى internalization، تدخل هذاك الانتيبودي الداخل في ويقتلها ويقتل السيل. That's how it does.
Okay. Question. هذه نسيت بوتينا تفضلي.
What challenge do researchers face in developing new cancer drugs?
What challenges?
les recherches de phase
Okay.
2.
To create a cancer drug. The challenges is developing a cancer drug. It takes really years. Okay, they start first design the drug. When they design the drug first, you decide about the structure first. Okay, based on all existing information. You write the structure, then you start making it. You start making the drug. You make the molecule. Then you start, they call it a preclinical research. Preclinical, they test only on cell line, on animals, for many years. They test toxicity, they compare it to other drugs. Then they move later on to phase 1 for a human, phase 2, phase 3. Then they will be approved. So how they approve the drug, for example? They approve a drug only when it is better than all the drugs before in the market. Need to have less toxicity, also show that extend the life of the patient. Let's say you have a drug for breast cancer, for example, or colon cancer. Okay, people, when they take it, they can live 5 years. If you bring another drug and you say, oh, when they take this drug, they can live for 10 years. Yeah, you need to give a longer life for people and less toxic. This is 2 things are very important for approving any drug. Need to show that extend the life of people and less toxic, the people will not suffer.
Ok. Merci. Est-ce qu'il y a d'autres questions? J'ai une petite question.
Hello.
Hello?
Hello?
Just I want to answer the question about what white skin people have more chance to have skin cancer more than the dark skin. It's about the darker skin have more melanin, so can protect them from the ultraviolet rays.
Yeah.
That's why.
Introduce yourself, Hamza Mitkour. Who are you?
PhD student in physics.
Theoretical physics.
Yes.
Okay, thank you for the question.
You are welcome.
Dr. CHENNA?
Oui.
Est-ce que vous avez bien entendu? Did you hear the question of Mr. Mitkour? I think
No, I answered the question.
No. I heard him answering. Yeah. Good answering.
Okay, do you have a comments for this comment?
No, I think he found it. He found it. It is, you can Google it. It's easier. So
I have just a question for myself, maybe 1 or 2 questions.
yeah, no problem. Yeah,
Do you
go ahead.
have any statistics about the drugs or about the people that have cancer drugs resistance? I mean, if you make all of human drugs and finally there are people that resist, do you have some statistics in the world?
I don't have them now with me or remember them, but I mean, I can send you the information. Yeah. So I think the drug resistance is always built when the person is treated for a long time. So if the person is treated only for a short time for that drug, they will not build a drug resistance.
Okay. And for what about allergies? I mean, this drug can develop some allergies as a collateral side of treatments.
Oh, I think allergy is mostly is for antibiotics, you know. So always when they ask before giving antibiotics here, oh, you have allergy to this or to this or to this, you know, they always worry. But people, for example, for monoclonal antibody drugs are humanized, you know, are humanized antibody. That means that the body will not reject them, really. So and they are the amount is less than regular chemotherapy and less often, you know, is given, you know, sometimes a dose every after a few weeks or so. So it's not kind of like chemotherapy. You need to give a person, you know, very often, and you get always directly to the blood.
If you ask you a very humble question, if you we want to ask you to compare between the radiotherapy or nuclear medicine therapy of cancers and this technology. So what you can say, because our students are medical physics, so they learn how to treat and to diagnose cancers with the radiations. So if you have to say something about your technology and our students' technology, so what you can say between the two?
Oh, I think each application, I think, is as I said, you know, at the end. So now it's getting into combination therapy. So some cancer now treatment, sometimes they give them some medication, then they go and they ask them to do radiation, you know, for 2 weeks, or you know how many sessions, you know. So there is now a combination of started now, and I think each one has, if the person is, if the drug, I mean, if the cancer is accessible, you know, can be, you know, kind of treated in a very specific location, you know, with the radiation. It is very helpful, the radiation, you know. But if it is in a location that it is difficult to access without damaging other area, so it's not going to be suitable, you know. So now I think it is. I think the doctor, the oncologist, sometimes, you know, decide about how the combination, you know, is added together, and it's not only radiation. I think there is no treatment for any cancer, only radiation, you know. So you need both, or you know, 2 or 3 together to slow down the whole thing. So you cannot say that, okay, radiation. You cannot compare radiation alone with medication, because
Technology,
yeah. So there is,
yes.
you know, because for clinical trial is it is difficult to really to imagine. If you have a new drug, let's say, what they do. Okay, you have a new drug, and they have 1,000 people are giving them the drug, and 1,000 people are giving them not the drug, placebo only. And they found out that the 1,000 people who are getting the drug are their tumor is shrinking, are improving, and the other one are not. It become ethical dilemma, you know, when the company knows that these people their tumor are getting bigger because they are not getting the drug, and the other getting the drug is a moral thing. Sometimes they stop and they start giving the drug to everyone. Even the clinical trial will stop, because become kind of unethical, you know. You have people, group of people are getting the drug, you are testing a new drug, are improving. The other one are their tumor is getting bigger and dying. So it is difficult to compare, you know, two systems. Imagine if you have a set of patients, you give them only radiation and the other one give them only drug, and you start noticing this
Yes.
group are, you know, what you're going to do. Here the يعني قضية أخلاقية هنا.
So the technologies are complementary.
Yeah, they need to, together since, because what is his name? There is a book they wrote it okay, about the cancer in the Arab world, and ويسموه Professor, I think Ahmed, I think, from Algeria. He wrote the chapter about Algeria, you know, about the treatment, what type of, I have it, you know, anyone want it, I can send you a PDF for this book, you know, it's available free. I mean, I can share it with you, you can share it with the student if you want. So but Algeria, you know, what is needed in Algeria is a big thing that we don't have. We don't have cancer registry. Cancer registry, there is one in Satif, there is one in Wahran, there is one in Algi, but there is no nationwide cancer registry. Here in US, in Europe, France, in all countries, any case, any cancer case is registered. You know, that person, what type of cancer, it go into database. يعني base de données في البلاد الكل. Donc, and you can go and do search, any researcher. Oh, let's say I'm going to see Constantine, for example. Okay, what type of cancer is the highest, for example? Or go to Wetsu, or go to, you know, all the information is there. We don't have one in Algeria like that. This is very sad. This is very sad, really. We should have Algerian cancer registry for all Algeria.
Yes. We have Dr. CHENNA last questions, because our students should leave now from the university, because it is 5 p.m.
I know. Me too. I have to go to work now.
Okay. So we have last question, please, from نجمة عشيري. تفضلي.
بالعربية أستاذ.
تفضلي.
بالعربية، معليش، بالعربية ما كاش مشكل. صح، القبيلية والشاوية ما نفهمهاش، صح.
ما نعرفهاش أنا ثاني.
اوكي.
ما يعرفهاش كيف يترجم.
أستاذ، احنا نشوفوا باللي الاهتمام كبير بزاف بالأبحاث حول الأدوية اللي تاتاكي الكانسير. هل الأبحاث اللي بالمقابل تهتم لي زيفي سكوندير هي ترقى بنفس المستوى؟
هي كاينه الان جزء، كاينه ادويه الان موجوده انها تهتم ثاني ب كما يقولوا السايد افكت، وش تاثير
جانبيه،
الاعراض الجانبيه كاينه بعض البحوث، وكاينه بعض الادويه اللي تخفف من الاعراض الجانبيه. الان مثلا بعض الادويه، مثلا واحد يعطوه دواء مثلا تاع ضد السرطان، لكن يعطوه ثاني دواء اخر اللي نقص من التاثير تاعو تاع الاعراض الجانبيه ثاني، وبالتالي ياخذوها بعين الاعتبار هنا كثير هنا، لانه مش حابين المريض كما يقولوا يعاني، وبالتالي ضرورة هذه أصبحت جزء من العلاج.
شكرا. مسيو سن أبو شنا، عندي ملاحظة فقط.
نعم.
يعني هل فكرتوا انكم ديروا فاكسينيشن تاع بريفنشن فاكسينيشن وقايه من الكانسر. كيما نديروا فاكسينيشن وحنايا اطفال من اجل الوقايه من امراض، هل ممكن نعمموا الفكره هذه على الكانسر وتولي فاكسينيشن obligatory for everyone؟
والله مع الأسف يعني ما كانش هذه لأنهم أولا لأنهم كان أنواع كثيرة من السرطان، وبالتالي يعني من الصعب باش تخلق فاكسان واحد تاع نوع واحد، وبالتالي إذا كان فرق في المستقبل كاين الفاكسان هذيك تاع سرطان الرحم، هذيك تاع المرأة كاين هذاك، لأنه هذاك أنه فيروس السبب تاعو أنه فيروس هذاك كاين فقط هذاك، لأنه السبب تاعو فيروس. لكن الأسباب الأخرى تاع السرطانات أخرى ما هيش فيروس، وبالتالي من الصعب
نعم.
يعني
شكرا جزيلا أستاذ شنا، مسيو شنا، شرفنا، وإن شاء الله عن قريب نزيد نشوفك في محاضرة، لأنه الطلبة عجبتهم بزاف المحاضرة واستفادوا. الأسلوب هايل والمحاضرة جدا واضحة.
أي الحمد لله باللي راهي المهم أهم حاجة استفاد.
إن شاء الله نشوفك عن قريب في محاضرات تقيس الدومين.
إن شاء الله نشوف إن شاء الله. المهم كاينة يعني وسائل التواصل إن شاء الله يعني. شكرا.
Have a nice day.
شكرا وأنتم كذلك.
Bonne journée parce que هما عندهم 8 دونك.
يا شكرا. هاي السلام عليكم.
سلام.